Good morning, everyone. Hopefully that's not too loud. Everyone can hear okay? Great. My name is Kathy O'Reilly. I'm the Vice President of Quality with Extended Care Canada. Welcome, everyone, this morning to this session on person-centered care. It gives me great honor to introduce our presenters today, and they will be presenting either as together or separately, and we have a fairly tight time frame in terms of presentations. We will have time at the end of the session for questions, so if you want to jot those down as you're listening and taking in the information, that would be terrific. So without further ado, I'd like to introduce our presenters today. First of all, to my immediate left, Mary Schultz. Mary is the Director of Information, Support Services and Education with the Alzheimer's Society of Canada. Mary is an experienced healthcare leader. She has provided individual and family counseling to clients facing crises associated with life-threatening illnesses, chronic disability, and cognitive impairment throughout her career. She has also helped to plan and implement healthcare programs both to an in- and outpatient basis for clients coping with chronic and palliative diagnosis. Mary obtained her bachelor degree in social work from Ryerson University and holds a master's degree in social work from York University Atkinson College. Sitting next to Mary is Lisa Meschino. Lisa is a postdoctoral fellow of the Murray Alzheimer Research and Education Program at the University of Waterloo, having earned her PhD in cognitive neuroscience in the Department of Psychology at the University of Waterloo. She's also a mixed artist media visual artist. With over 25 years of painting and drawing experience, she is committed to the arts-based research and community wellness initiatives that enable persons with dementia to make meaningful contributions to their lives. She's guided by a relationship-based care philosophy and phenomenal methods. Excuse me. Lisa's postdoctoral research focuses on the therapeutic potential of creative arts for improving the quality of lives of persons living with dementia and their care partners. She's a collaborator in developing the Gather at the Gallery art program for the Alzheimer's Society at Kitchener-Waterloo, and she is studying how involvement in a creative art program can create a sustainable experience and meaningful relationships and engagement in the community for persons with dementia and family partners. Sitting next to Lisa is Jennifer Benata. Did I get that right? Benanata, sorry. Jennifer is a graduate of social service work and is currently the Director of Resident Family Services at Specialty Care Bloomington Cove. In this role, Jennifer is responsible for providing support to residents and families as they transition into long-term care. She's an advocate for quality dementia care. Jennifer is also in the process of implementing life skills stations which encourage residents to remain active as the practice daily routines and life skills that were previously part of their everyday lives, so to encourage that in later years. In keeping with her passion for contributing to those affected by Alzheimer's or dementia, Jennifer has worked diligently in Bloomington Cove's annual Walk for Memories, which has raised over $36,000. Leslie Santos is the Manager of Quality and Resident Support at Shepherd Village and is also the Behavioral Support, or the BSO lead, at her home. She's a registered social worker with 10 years of experience working with the elderly population in a variety of settings, including hospital, long-term care homes, and government settings. She is a member of the Central East Lynn Health Care Professionals Advisory Committee, and at the Ontario Senior Secretariat, she was a member of the Federal Provincial Territorial Safety and Security Working Group, who coordinated the Elder Abuse Working Forum in 2007. She's also taught social worker, community service worker programs at local community college in her area, and has mentored social work students as well as postgraduate students. She possesses a master's degree in social work from York University, where she obtained an entrance scholarship, and her master's thesis is entitled A Critical and Postmodern Analysis of Ontario's Elder Abuse Programs and Service. It's where domestic violence was 25 years ago. She is a member of the Ontario College of Social Workers and she's a member of the Ontario College of Social Workers and Social Service Workers and the Ontario Association of Social Workers. Patricia Boucher is the Vice President of Prevention and Public Services Health and Safety Association of Ontario. Patricia has over 30 years of experience in the community and healthcare sector, 20 of which have been in the field of occupational health and safety and disability prevention. She has a Bachelor's of Health Science and Nursing and a Master's degree in Health Services Management, is a Canadian Certified Occupational Health Nurse, a Canadian registered safety professional, and a certified disability management professional. She's employed with the Public Service Health and Safety Association of Ontario, where she's Vice President of Prevention Services. She has a strong record in developing strategic partnerships with stakeholder organizations, provincial associations, unions, academic teaching and research organizations, government ministries, and is the health and safety community both at the provincial and national level. She's co-chair of the Behavioral Support Ontario Education Consortium and has extensive working knowledge in the development and implementation of health and safety management systems. I'd like to welcome all of our speakers, and I'll turn it over to Mary to start us off.
Hi, everyone. Well, that's an intimidating introduction of all these folks. I don't know about you, but I think it's more important to find out who all of you are. And from a national organization, I always like to know if there's by any chance anyone from outside the province here in the room today. Is there anyone here from outside Ontario? Welcome. Where are you from? Oh, welcome. Wonderful. It makes everyone else not complain about their commute this morning, I think. If there's anyone here who is living with dementia or a resident of long-term care, a special welcome to you and also to any family members who might be here. I'm also curious to know what kind of a mix we have in the group, so hopefully as we have questions later on in some conversation, we can be a little bit more focused. In terms of allied health professionals, PT, OT, recreation therapy, pharmacy, hands up. RNs, nursing staff, great. Personal support workers, administration, management. Okay, cool. Any chaplains here? Spiritual care? Okay. Well, I know there's lots of people I've missed, but it just gives us a little bit of a flavor, so thank you. So you know who I am, and we've got some support for the work that I'm going to be chatting about today. What's important to know, though, I think, is that we get unrestricted educational grants, which mean people very kindly give us money to do the work that we do without any strings attached. So we report on what we do, but they don't influence the work that we do in any way. So this is a quick overview, and I'm speaking first for a reason, is to kind of set the stage for what we're chatting about today. This is information that's going to be very familiar, I suspect, to many of you. Certainly not going to read a lot of slides to you today, but wanting to just set the tone in terms of the growing numbers of people with dementia living in Canada. What may jump out at you is the number of people who are estimated to be under the age of 65. We all know age is still the biggest risk factor for developing Alzheimer's disease. But that's not to say that people are not being diagnosed very earlier and earlier, which is, of course, what we want, but has lots of implications. And the numbers, of course, are growing. And you can see that if we do nothing, we're looking at that 747,000 number changing to 1.4 million people within a generation. So when your kids are growing up, we're going to have a tremendous problem, bigger than we can imagine, unless we do something differently than what we're doing now. Specifically, we're talking about long-term care, of course, here today, and this is some information. You get different stats depending on what you read, but these are ones that we think are fairly reliable. So if you've got some new information for us, I'd love to chat with you later on. But I think the bottom line is something that we all know in our lived experience of working in long-term care, that the majority of people who live in residential care have a form of dementia, typically Alzheimer's disease, and 70% of people who are living with this disease are going to die in a long-term care home. So my experience, maybe yours as well, is no matter how well-resourced you are, no matter how wealthy, no matter how together your family may be, no matter how committed you may be, the chances are that this disease is bigger than all of you put together and more, and you're going to need the kind of care that is offered in a long-term care home. Again, I won't belabor this, but our Rising Tide data, which many of you will be familiar with, and if you're not, please go to our website at alzheimer.ca, talks about the actual implications in long-term care of the growing numbers of people with dementia. And these numbers, and I understand these slides are available or going to be available afterwards for everyone, so no need to scribble things down. But basically the picture is that despite everyone's wish to live in the community as long as possible, again, barring something dramatic changing, we're going to be looking at more and more people needing long-term care, and that we aren't prepared for the kind of resources that are required to care for people in long-term care. So now to get to the more interesting stuff, I think, which is what does a person-centered philosophy mean? You hear a lot about that these days, and one of the things that we at the Alzheimer's Society of Canada are working on is getting away from kind of all the cliches that you hear. When I ask people, are you delivering person-centered care? People will say, oh, yeah, I am. We are. We're working on it. And when you drill down, you find out, as well-intentioned as that may be, there's an awful lot of richness to developing a really strong culture of person-centeredness that goes way beyond having a picture of someone outside their room or knowing that they like strawberry jam in the morning. And I don't mean to be facetious, but quite often I find that people feel that those are the check boxes that demonstrate that I'm being person-centered. And while they're important, particularly if you don't like strawberry jam, it's not quite what we're talking about in terms of the dramatic culture change that's required to deliver on the kinds of things that you see in the slide. So it's really about truly stopping and pausing and thinking about, do I really know Mary as a unique person? Yes, she has dementia. Whoopee-doo. What do I really know about her and her family and her priorities and her values and her history? And why should I know that stuff? How is it going to impact her experience of living in her own home as her dementia progresses? So it's really about trying to improve the experience of living regardless of where one is living. Today we happen to be talking about long-term care and the kind of support that the rest of us need to give in order for that to happen. One of the supports that you'll see here is staff. Staff need to be treated in a person-centered way if we hope that they are going to be, in turn, responding to people in that kind of respectful manner. And of course, we'll be talking about leadership. I was encouraged to see so many hands of people who are in leadership roles in long-term care. No matter how much I read, no matter who I talk to, no matter what innovation I learn about, it all seems to come right back to walking the talk and leadership really buying in. And some of the market research that we've been doing will speak to that. So what does this really mean when we're talking about what it really looks like in person-centered care and in a long-term care home specifically? And if we had more time, I would love to have shown you some videos of people with dementia talking about what this really looks like. But these are some of the tenets, some of the overall principles that we speak about. And enjoying every day probably seems very, motherhood. But we're really talking about throughout the continuum of the disease. So even in the late and end-of-life stages, what are we doing and what is our commitment to those individuals and families to make every day the best possible experience for that person? We all automatically jump to think of things like pain management, and anyone who's ever experienced pain, which I suspect is everyone in this room, will know that that's pretty darn important. But that's often where the conversation seems to dwindle away. And there's a lot more that we can be talking about when it comes to, regardless of the stage that the person's at, what might make that experience of the day enjoyable. Safety and independence, finding that balance. We get inquiries all the time. How can I help my mother to remain independent and yet make sure that she'll never fall, make sure that she'll never wander out in a snowstorm? Of course, we want to avoid those terrible tragedies, but where's the balance? And it's going to be different, of course, for every person. And what's the tolerance for risk? Very big issue. That's a lifelong trait that we need to find out. How risk adverse have you been all your life? If we did a poll in this room, we'd see all kinds of diversity about how much comfort do you have in playing the stock market? How comfortable are you going out in the morning without your gloves and your mitts and your hat when you're not sure what the weather report's going to look like? Very basic stuff. We all have a piece on that continuum. Meaningful activities. We're not talking about cookie cutter programs. We're not talking about, God forbid, what I'm still seeing, people with dementia lined up in front of the television with their heads falling over. We're talking about meaningful. We're talking about fun. We're talking about the things you and I like to do. If you don't play bingo now, chances are that's not going to turn your crank later on in life, right? If you love to knit now, if you love to fiddle with mechanical things, there's a good chance there's going to be a part of that that's still going to be fun for you. So what is it that's making life interesting? Whatever makes it interesting now, there's a good chance that that's going to be a clue for later on. Anticipating responses to changes in behavior. This is nothing new to all of you. I'm certainly preaching to the converted here. But this is about calmness and consistency. This is about identifying triggers. We're not really all that good at that because those triggers are going to be very different for each of us. But really helping to anticipate when someone is going to be in trouble. Family. This is a big one. We could be doing a 3-hour session on families alone. They can be the bane of your existence, and you can be the bane of theirs. So what we'd love to do is look at person-centeredness where families and staff actually are a team, and I mean that in the real sense of the word, not the stuff that gets into the reports that we write. And then, of course, the whole issue of caring for people through end of life. So what are we actually trying to accomplish here? Well, the Alzheimer's Society of Canada is working with a lot of partners for this ultimate goal, which is, yes, quite idealistic, but we are convinced it's absolutely doable. That person-centered approach to caring for people with dementia in long-term care specifically is going to become the norm rather than the exception. Sounds good, but how on earth do we do that? Many of you may have already read, and if you haven't, I encourage you to do so because it's quite an easy read. We started with a very basic document. It's not the last word by any means, but it's a snapshot of what the evidence tells us good person-centered care looks like in long-term care. And it's a lot of the stuff that I just talked about with a little bit more detail. So this is available on our website for downloading, and by the way, of course, everything we produce is in English and French as a national organization. So for those of you from Francophone parts of the province, please feel free to look at the French version. But this looked at what do the guidelines exist right now and what do we know so that we're all at least building on the shoulders of the work that's already been done by others. And this included guidance from people with dementia and family members about the lived experience of person-centered care in long-term care. So it's not just academic sources that we looked at. So that was to give us kind of a platform. But then what did we do next? Well, we're never in the business of academia. We're a practical organization, and we need to build on academia, but the framework, the guidelines were not where we wanted to stop. That was just where we wanted to start. So we put together a steering committee. It's a little bit big, but I couldn't say no to the really stellar group of people who wanted to be part of this work. Folks who really were excited that finally the Alzheimer's Society is saying, you know what, long-term care matters. People with dementia at the late and end-of-life stages deserve quality care in a way that people who are in the earlier stages expect that. And staff in long-term care want to do the right thing, and they want to produce the kind of care that we all would be proud of. So let's get it together. And we got a lot of excitement around that finally we're putting the spotlight on, let's face it, a part of the healthcare sector that often folks want to kind of turn their eye away from or don't consider to be the most exciting or sexy part of the healthcare system. It's the healthcare system many of the people that contact us are most afraid of needing in their later years, particularly as they become more impaired. And we said, you know, it doesn't need to be that way. So the steering committee is quite a mix of people from academia, clinicians, family members, etc. And there may even be some of you here in the room today. But we asked them, how shall we start to build on what we know already exists? So we wanted to put this into action. This is not, as I say, an academic exercise. So we decided we were going to do market research, not academic research, market research, where we went into 6 long-term care homes across Canada. Only 6 because we only had enough money to go into 6. But Canada is basically covered, the various regions of Canada. And in Ontario, there happen to be 2 homes just because of the size of the province. And we identified the homes that we were going to go into in more art than science. It was kind of a combination of looking at third-party collaboration and corroboration. So things like, are there any homes that have actually got accredited for dementia standards through CARF, for example? Are there homes that are actually writing about their journey of person-centeredness and they're actually going on record that we're doing this kind of, we're working on this kind of approach? So we really pulled together any information that we could. So what was important when we were looking at these homes? Well, whatever we learned, we wanted folks like you to be able to say, yeah, that sounds like my home. That sounds like us. So we needed to be somewhat representative of the long-term care home industry. And what I think is important to tell you is that we are not doing any of this work without long-term care providers right at our hip. We're not in the business of long-term care. The Alzheimer's Society doesn't know long-term care. You guys know long-term care. So we wanted to make sure that anything we say, anything we do is informed by people who actually work and live in long-term care. So what we learned was this needed to be a group of long-term care homes that are representative of our vast geography, different funding models, unionized and non-unionized, urban and rural, all kinds of different models, and different sizes of homes, so that whatever we learn hopefully looks like something you might call the place where you go to work. How did we do this market research? Well, I've alluded to that a little bit. We chatted with lots of different people, and we hired a market research firm to go in and actually do this work on our behalf. And they talked with management and staff about how do you actually do person-centered care. We know the theory, we know what it's supposed to be, we know it's respect, we know it's this and that, blah, blah, blah. And there's a lot of blah, blah, blah out there about person-centered care. But how do you actually make it happen? So they were very honest with us, and we were so honored that they let us come in and learn from them. We learned from family members who told us what it meant to be in a home that said that they're trying to be very person-centered. Warts and all, like what's working and what's not working so well. We tried to talk to residents, and we didn't do very well, and we've got to get better at that. Quite often, families told us they're having a bad day. Yes, I said Mom would come, but she can't come and talk to you today. What are you going to do? And we got to get better at that, so it's not as reflective of residents' input as we would have liked. We talked about all the approaches that they use. What's innovative that you're doing? What could other long-term care homes learn from you? What have you tried? What hasn't worked so that other people maybe can avoid some of your mistakes? Do you have lots of information you can share? Templates, orientation models, or what have you? So we learned lots of different stuff, and I'm not going to be able to give you a lot of detail for a whole bunch of reasons right now. But what we learned, of course, is that these homes are not perfect. They have been chosen because they are self-professed as we are really serious about trying to be more person-centered in our approach, putting the resident and family at the heart of what we do. But we don't have it all figured out. And certainly the Alzheimer's Society is not saying these guys are perfect. So none of us is sort of holding these up as a shining example, but as examples. But there were certainly some commonalities that came through. And the little acronym that's helping me to remember kind of the themes of what we learned is person-centered pearls. In other words, pearls of wisdom, we hope, as we kind of learn from these homes that have been in this path for a while. So what are they? Well, I don't think there's going to be anything terribly shocking to you. There wasn't to me. In fact, it was more validating. But also, the proof's going to be in the details. The devil's in the details, as they say. This is going to be pretty self-evident, but how do you actually do that? We got some very exciting, interesting ideas from these homes. Things like asking family members to do the orientation tours for new family members coming in rather than staff. Having them say, you know what, this home isn't perfect, and here are some things that as family members we're trying to change, but you know what, they're doing a pretty good job with X, Y, and Z. And yeah, you're asking about this, I asked about it too, and I've seen some improvement, or whatever. It really has been very creative, and family members feel like they're really getting the straight goods because they're getting it from a peer. That's just one example. Talking to families about dementia, helping them understand why they may come in and Mom may not be bathed when they come in the morning. Helping them understand that being person-centered might mean that Mom wants something different than what you want for her. And that's going to be something we're going to have to work out together. Focus groups of family members, not once, not because accreditation's coming, but because we really want to understand how to keep working with you in a way that's meaningful. Lots of interesting stuff that we're going to be mining. Care, no surprise there. Interesting ideas around things like intake. Very interesting thoughts about how do you actually do that first initial session with individuals and families when they walk in the door. You know that saying where you only get one chance to make a first impression. What does that look like? And how can you really engage people from the minute they walk in that door, as terrified as they may be? And I don't know about you, but families that I meet generally fall into two camps. It's either the family that's going to say, I'm going to watch every step you take because you better care for my mother the way I expect you to, or you're going to hear from me, or you're going to hear from my lawyer, and did I mention that my brother is a justice of the peace? You know, blah, blah, blah. Or families come in so terrified that they're like, oh, we're just so grateful, and just call me anything you want. We'll do any, no, whatever you say, that's just fine. You know, kind of the two camps. How can we improve that? Well, care is really one of those areas, and intake was an interesting area of focus for a lot of these homes. Not only that, but towards the end of life. What kind of processes have some of these homes put in place that really honor the fact that people are dying in their home and that we are all there to support them? Interesting things like dignity robes rather than shrouds. Interesting things like carts that go around the home with comfort items for family members who are waiting for family members to pass on. What can we do just to make that experience as comfortable and as person-centered as possible? So we're going to have some interesting things to share there. Processes, lots of processes. I won't go into them now, but a big theme was learning organizations. Do we all say that we belong to learning organizations? Chances are you do. I like to say that too. But I know in my heart we've got a long way to go to be a truly learning organization. Talking about processes around staffing and flexibility. Many homes talked about no one is allowed to say, that's not my job. No one is allowed to say, I'm sorry, I wasn't here yesterday. No one is allowed to say, I just got back from vacation. I'm sorry, I don't know. And if they do, it's a performance issue. Those kinds of things that are just interesting in terms of how do you change the culture. Environment. This is a big one. We know all about that. But if you go to the dentist, do you consider yourself a dental patient for the rest of your life? When you go to see your family doctor because you've got a cough, are you a person with a cough for the rest of your life? When you come to this conference, do you introduce yourself and say, hi, I'm Mary, I'm a person with a cough? No. Your medical care supports the rest of your life so that you can get on with the business of living. And long-term care homes that are very person-centered tend to say, we're here in the background to support you so that you can live your life. We don't revolve around the fact that we are a skilled nursing facility. We talked briefly about activity and recreation. This is not about programs. This is about flexibility. This is about fun. This is about learning. This is about being geared to people's interests. Lots of work here, and I'm sure many of you know a lot more about this than I do if you're in recreation therapy. And it's interesting how there's a backlash now that I'm reading about music therapy. Used to be, I just love rock and roll. When did it become a therapy? Well, you know what? What are we doing about that? I happen to love opera. Is that opera therapy? I don't know. Maybe it is. But it's an interesting thing to think about. Are we medicalizing the stuff that you and I don't think about as a medical treatment when we go home? Leadership, huge amount of learning here. Leading by example, walking the floors, being right there to help problem solve, and really living the kind of experience that you expect families and staff to be exhibiting as they care for people with dementia. And staffing. This is a huge one, and nothing that's going to surprise you. Consistency, consistency, consistency. Education, and really treating staff in the way that you hope that they are going to treat the residents and families, and lots of innovative stuff to learn there. So we've learned lots of stuff. We've got lots to digest, lots of reports to read, and so this is why I can't share with you a whole lot more detail, but I'm hoping that you got a bit of a flavor of the kinds of things that we're learning and we're going to want to build on. So what's next for us is we're actually going to be coming back to that steering committee I mentioned earlier and saying, okay, let us share what we've learned, a little bit like what we've just done this morning, and figure out, okay, how do we now amplify and learn from and build on these kind of innovative strategies? How can we support the long-term care home industry? So how can we hear and respond to what we've learned in this market research, which is really about the long-term care homes saying, we want to talk more to each other about the challenges that we're experiencing in care in real time. So, for example, if we're thinking of getting rid of our dementia care unit and just having everybody back together again like it was 20 years ago, I'd like to talk to other people who've already done that and learn from them about, is that working for you, or what can we do? So we want to kind of figure out how can we help all of you talk to each other more, probably through organizations like OLTCA across the country. But the other big area that we need to focus on is how do we help families? How do we overcome some of this fear of, oh my God, are we really looking at long-term care? How do we overcome their hesitation to even consider long-term care, especially early in the dementia journey? And probably most importantly, how do we equip families to come in with the mindset that they are a team member who has valuable information to share and will truly be accepted as an equal member of the care team when their relative lives in long-term care? How do we help families and staff truly become teams? We get a lot of appetite for that. We've got a lot of people saying, if you can do that, our jobs are going to be a whole lot easier. But you can imagine from your own experience, that's not going to be an easy road to hoe, but that's something that's clearly come out. We have got to work together. Because if I'm ducking behind the nursing station every time I see so-and-so's daughter coming down the hall, you know what, we're probably not going to get very far. So we've got to figure that out. And that's the kind of stuff that we're going to be discussing in the next few months. So I would suggest, if you're interested in learning more, just keep an eye on alzheimer.ca. We have particular sections for person-centered care. There's going to be more information there as we're able to kind of distill all of this market research and share it with all of you. So please feel free to keep an eye on that. And if you're interested in getting on our Champions mailing list where you'll get a sneak peek and a little bit of a preview that stuff's on our website, just drop me an email and we'll add you to our distribution list. So thank you, and we'll look forward to hearing about some examples from our colleagues here about how person-centered care is being delivered. Thank you.
Oops. Thank you. Good morning, everyone. Jennifer and I are delighted to be presenting here today on Partnering Together for Change at Specialty Care Bloomington Cove. There we go. The purpose of this presentation is to share the critical reflections from the culture change process of one of the 4 culture change coalitions in the Partners in Dementia Care Alliance project, that of Bloomington Cove. In mapping out Bloomington Cove's culture change journey so far, we'll provide some background information on the larger research project of the Partners in Dementia Care Alliance. We'll give a brief overview of the project and its partners and its approach of appreciative inquiry. And then we'll describe the road of Bloomington Cove's specific culture change process to date. We'll be identifying the challenges or speed bumps experienced along the way and outlining how those challenges were transformed into ramps to opportunities that have supported their work. So the Partners in Dementia Care Alliance is a collaborative research initiative focused on improving the dementia care experience for persons with dementia, family members, and staff in both long-term and the community care settings. The PID Alliance is co-led by Dr. Sherry Dupuis, a professor and director of the Murray Alzheimer Research and Education Program at the University of Waterloo, and Dr. Carrie McHaney, associate professor in psychiatry and behavioral neurosciences at McMaster University. The aim of the Alliance is to facilitate sustainable culture change in dementia care from a more institutional model to a more relationship-centered partnership model of care. Our process is a collaborative one that ensures the voices and experiences of everyone in the care process are heard, respected, and included in the decision-making. And it uses an appreciative inquiry approach to explore new possibilities. So this visual representation here depicts the teams that form the PIDC Alliance. They include a research management team of researchers from various universities and representatives from each of the long-term care settings and organizations involved in the research. Also, our culture change coalitions made up of persons with dementia, family members, and staff at all levels. We have 3 long-term care homes, Bloomington Cove being one of the 3, and a community care-based setting made up of organizations in the community who provide care for families who are experiencing dementia. There are also other key stakeholders, such as dementia care educators and specialists, knowledge translation specialists, a range of community and long-term care support service agencies, policymakers, and researchers. So in working with those in the long-term care sector, it became very clear to us that the traditional problem-based approaches don't work.
Traditional approaches to problem solving tend to focus on the negative, searching for root causes of failures and problems in order to fix the past. They make people feel powerless and overwhelmed by all that's gone wrong. What we needed was an alternative approach to culture change that would help organizations identify and build on the strengths, gifts, and assets that brought life to the organization. And this brought us to Appreciative Inquiry. AI focuses on what is working best, what is happening when people and the organization are at its best. It searches for the root causes of success in order to identify what's possible for a better future. What were once obstacles now become ramps to opportunities. And this positive focus tends to make people feel empowered and engaged and excited about change. Now, Appreciative Inquiry process typically involves 4 phases, the 4D cycle. It's called discover, dream, design, and deliver. In the first phase, you discover and appreciate the stories about what is working well within an organization in order to identify the strengths that can be applied to other areas. In the second phase, you dream of what might be by envisioning how you want things to be for the future. In the design phase, you determine what should be by developing concrete strategies to put ideas into practice. And in the last phase, you deliver. You create what will be. In this phase, strategies and projects are put into practice. Now, we added the dawn phase to the AI process after our experiences with our first 2 sites. These sites showed us that it was critical. It was a critical phase in laying the groundwork for culture change. Our dawn phase was all about building trust and relationships, creating a common knowledge base, and learning from each other how to work towards a collective vision.
So as Lisa stated, the presentation specifically traces the culture change process, or the CCC, at Specialty Care Bloomington Cove. Bloomington Cove is a long-term care home situated in the rural setting in Stouffville, Ontario. It is one of the few long-term care homes that's devoted exclusively to dementia care, and we're a home to 112 residents. Our Culture Change Coalition, recently named Partnering Together for Change, was formed in January 2011. It includes residents, family members, frontline staff, middle and upper management, members of the broader community, and researchers from MAREP.
So, can everyone hear me? Am I coming through okay? Good, okay. So, in the next couple of slides, we're going to share Bloomington Cove's process map. This is our road map here. It looks a little bit like a tree, but it's a road map, highlighting the speed bumps and ramps to opportunities experienced thus far over the past year and a half since the formation of Bloomington Cove's Culture Change Coalition. So, our dawn phase became an important space for building trust and creating a collective vision. The phase involved working with Bloomington Cove to determine who should be involved in the Culture Change Coalition and ensuring that all voices are represented, developing guiding principles for working together and creating a safe space for our work, exploring personal and group expectations, building capacity in a relationship-centered, authentic partnership approach and appreciative inquiry, and working together to adapt a care profile tool to measure the quality of the care experience from diverse perspectives. From the outset, all CCC members, from researchers to the Bloomington staff and family members, were open about describing their mixed emotions, being both apprehensive and confused about what seemed like a vague and, frankly, unknown process, to being open and excited about the possibilities, motivated for change, and curious about what we were all getting involved in. We identified a number of challenges or speed bumps in the first 6 months of the process that are common among a lot of long-term care spaces. First, as a diverse team, we all brought to the meetings our own individual experiences, understandings, and priorities. In the beginning, shedding these individual agendas was a necessary, if difficult, step toward a common vision. As soon as we had our CCC up and running, we experienced several staff turnovers, and throughout the process have had to regularly adapt to fluctuations in membership structure and size. Also, a number of our personal assumptions were challenged early on, including those around decision-making. Until we had open dialogue that brought our concerns to light and drew on our shared knowledge and experience, the voices of persons with dementia were absent at our early meetings. And not surprisingly, we struggled with how to be appreciative when the tendency to outline problems and want immediate outcomes is so ingrained in our work cultures. So we were challenged with suspending these tendencies in favor of learning together how to be appreciative. The early days of our dawn phase also saw a lot of important dialogue around old ways of communicating, specifically around issues of who speaks for whom, and not understanding each other's language and jargon, and feeling safe to speak without being judged. So an important factor that helped us navigate these challenges from the beginning was the commitment to the project by the internal leadership at Bloomington Cove and the external support for the project at the larger organization's level at Specialty Care. We addressed the other speed bumps by spending a lot of early meetings on ensuring that we all understood the philosophies guiding our process. We worked together to develop guidelines for how we would create a safe space, value diverse perspectives, and make collaborative decisions. We learned that what we needed to come to a place of understanding of the different concepts and the shared purpose before we could come together as a collective. We recognized that changes in the membership was a reality in long-term care settings, and we adjusted to this reality. We felt we needed to allow for the flexibility, and we worked together to make sure that new members were updated on the project and our process. We created a number of activities to challenge personal assumptions, including having all coalition members engage with direct quotes from people with dementia about the consequences of being excluded and what it would mean for them to be included. We considered attending resident council meetings to tell residents about the project and find out from them how we might best include their voices throughout the process. And in addressing missing voices, we also created an exercise where we mapped out all the key stakeholders involved at Bloomington Cove and how we might, and reflected on what voices were not represented yet in the CCC and how we might engage those voices. This led to concerns about not having enough frontline staff involved and the development of strategies for inviting personal support workers to join the CCC. In attempting to chip away at the problem-focused approach, we developed multiple icebreakers that challenged us to think appreciatively. We conducted appreciative interviews with each other, and we modeled an appreciative approach in all our work at Bloomington Cove. In our learning to appreciate the importance of the process as well as the outcomes, we created Appreciative Inquiry arrows, that diagram that you saw earlier, that clearly showed us where we were in the process and the goals of that phase. We also ended each meeting with 5 key takeaways that highlighted the tangible things we were accomplishing together. In August of 2011, we decided to host a launch of our Culture Change Coalition, where we could showcase the work we were doing to the broader community. The launch was an opportunity for us to celebrate what we were doing and what we had accomplished to date. The involvement in the launch of a local MPP and administration from the larger specialty care organization made coalition members feel like we were making an important contribution, not only within Bloomington Cove, but also beyond the Cove. A number of key events happened after our launch. In the fall, there was a major water crisis at the home that resulted in the facility closure. This was a frustrating time for the researchers as it put our work on hold for several weeks, but it ended up being a real possibility for the Culture Change Coalition. Outraged by the negative publicity the home was receiving, the Bloomington Cove community came together and led by the members of our CCC for the collective good and as a way to challenge the stigma associated with long-term care. One of our members said, "Our focus became clearer after the closure. At our very next meeting, we began to talk positively about the process and to leave negative baggage behind." The cohesiveness of the group became more apparent after weathering this storm together. Family members felt empowered to begin to challenge a problem-based family council, which led to the family council rebuilding itself with an appreciative focus. While low resident attendance persisted after the facility closure, frontline staff on our CCC began bringing residents with whom they worked to the meeting. At the end of our first year, there was a rejuvenation in the Family Council, increased flexibility in and commitment by membership, and an increased sense of cohesiveness among the group, an increased understanding of appreciative inquiry goals, and a collective readiness for the next phase. So discovery, being the next phase at Bloomington Cove, it was about empowering and building understanding and ensuring inclusion. We began discovery with a greater openness to what would emerge and to see possibilities, and members were demonstrating how they valued one another. A key feature of appreciative inquiry is including as many voices as possible in discovering what is life-giving about a community. One of the challenges we faced in the discovery process was around mobilizing the diverse perspectives that make up Bloomington Cove. We needed to find ways to engage all key stakeholders in the process. In particular, we experienced challenges reaching frontline staff and in capturing resident experiences, especially for those who needed other ways of communicating beyond verbal communication. Staff and family members worked together to address these challenges by hosting information booths and sessions with coffee and snacks several times throughout the process. Leadership also provided time for staff to participate in the discovery process during their work time. We also developed a strong relationship with the recreation staff and adopted creative ways to capture the lived experiences of residents at varying abilities, including attending resident lunch clubs and using art-based activities. As we gather more stories and experiences, we were challenged by the need to deepen our understanding and practice of appreciative inquiry, specifically what it means to articulate challenges within an appreciative framework. Together, our coalition re-examined and practiced a form of AI that is inclusive of all experiences. We also worked to create language and questions we could use to reframe negative experiences into understanding the possibilities of those lived experiences. When we began to analyze the data, all CCC members wanted to be involved. We were excited about this taking ownership of the process, but it brought up issues of ensuring inclusion yet respecting privacy and protecting confidentiality and anonymity of those who agreed to share their experiences in a community where everyone knows everyone else. We worked to develop shared principles for how we would protect individual identities. The enthusiasm for the analysis process soon was dampened by a sense of apprehension and a feeling of unpreparedness in handling the data and interpreting it. We shared some data analysis together as a group and as a means of helping coalition members learn about analysis and gain confidence. And we also created a template, a set of guidelines to assist each member in their own analysis of the data. Two ongoing challenges we grapple with continue to be finding effective ways to communicate with the wider Bloomington Cove and specialty care community and adapting to changes in membership. We're working with our new knowledge translation specialist to identify ways to better communicate aspects of the project and learning from what some of our other CCCs are doing. And as a start to communicating a more solid sense of who we are and what we are about, Bloomington Cove, to the wider Bloomington and specialty care community, our Culture Change Coalition has named itself Partnering Together for Change.
So in the 2 years that Bloomington Cove has been engaged in the Culture Change Project, we've already seen numerous changes and put into practice some of its learnings. Reflecting on the activities and accomplishments of this initiative, we celebrate the fact that the home is transitioning from a medical model of care to a person-centered social model of care. Historically, there's been a strong focus on care and scheduled routines, but changes have already been made. For example, increased education and leadership has really improved the ability for decisions to be made with residents as opposed to for residents. Also, we are taking steps to make the environment feel like home. We offer a flex breakfast and family-friendly fridges. We organize social events where residents can feel at home enough to invite their grandchildren to come for coffee or tea. We have a greater sense of validation in knowing what we're doing well. Through the focus group discussions, we learned that family members and staff consistently identified Bloomington's strengths. We now have a wider appreciation and a wider application of Appreciative Inquiry in family member visits and in our resident services. One thing that worked very well was art-based discussion groups provided a social opportunity for our residents and staff. The art projects were facilitated by residents as a way of gathering their stories and experiences. We love the structured but unstructured nature of the program and the flexibility that it gave residents for engagement and expression. We hope to learn more about training staff to continue to develop these activities and provide residents, even those with low communicative abilities, with the opportunity to engage with relationships with staff.
And so our work continues, and we are very excited to move into our dream phase of what Bloomington Cove could be and design a plan that puts our aspirations into practice. So thank you very much. Thank you.
Good morning, everyone. My name is Leslie Santos, and I'm the Manager of Quality Improvement, as well as the social worker. I wear two hats at this home. So, Shepherd Village is part of a Christian community, but today I'm going to actually talk about the long-term care side, and that's where I'm employed. And today I'm going to talk about the best practices in helping manage or deal with responsive behavior. So you're going to hear frontline, nitty-gritty stuff. So hopefully it wouldn't be too confusing for everyone here. So Shepherd Lodge, we were very fortunate in that we were one of 5 homes in Scarborough that received the Behavior Support Ontario funding. So the BSO funding works in different ways. In our LHIN, the Central East LHIN, they actually funded us to hire frontline staff to deal with the behaviors on the units. So we are very blessed and fortunate and proud about that. And we basically have 252 beds, but we have responsive behaviors throughout our building. We have a locked unit on our 2nd and 3rd floors, but again, all the behaviors are on all of the floors. And so we have various diagnoses. We have Alzheimer's dementia and Lewy body dementia, vascular dementia. However, there is an increase of residents with dementia mixed with mental health disorders. So that's very challenging in its own. And we actually had 83 residents with responsive behaviors in our home. That has now decreased to 52. This is my team. RPNs at the top there, and the PSWs here at the bottom. 6-lady team. So the aim of the BSO team is to reduce the number of responsive behaviors by 50% from 83 to 40 by next month. And these staff members, they work varying shifts. They work days, evenings, and weekends, 7:30 to 3:30, 2:30 to 10:30. And we sent them to all the behavior training. So we sent them to PIECES, we sent them to GPA, which is Gentle Persuasive Approaches, You First, and Montessori Methods for Dementia. And most of these staff members actually held positions in mental health institutions as well. So that was our launch. I won't go into that. Our mission and vision is to basically, the whole premise of this team is to teach the frontline staff how to manage the behavior using specific techniques and approaches. Okay, it's kind of like a leadership role kind of thing. So we actually have a caseload of about 10 residents. We don't want to surpass that so that we could infiltrate change. But we do have 10 of the most challenging residents on our case management list. This is our value statement: see me, understand me, and help me live with respect and dignity. What I'm going to argue to you today is the utilization of and application of PIECES, GPA, Montessori, a behavior assessment tool, a visual board or a whiteboard. Behavior rounds are all best practices in managing and dealing with responsive behaviors in long-term care. So what are responsive behaviors? The research suggests that there's verbally non-aggressive, so you have the resident who constantly asks you questions over and over again. Verbally aggressive, you hear the cursing and the swearing. Physically non-aggressive, where they wander to each of the residents' rooms, as well as physically aggressive, where they do violent things to the staff. This is the not-so-fun part of dementia. And we always encourage the staff and remind them that all behavior has meaning. Do not normalize it. Oh, yeah, that's Betty over there. She always goes into other people's rooms. She's going in there for a reason. You know what I mean? Whether she's looking for a bathroom and things like that. I'm just giving you examples. So a responsive behavior is basically it reflects a response to something negative within themselves, clinically, or within their environment. So that's what they're reacting to. And it could be overstimulation, could be understimulation, it could be caused by pain, it could be caused by UTI, a urinary tract infection, constipation, and the environment itself. Is it too noisy? Is it too soft? Is it too dim? Things like that. So we implemented 4 change ideas in our home. We had implemented a visual board, a behavior assessment tool, rounds, only focusing on behaviors, and Montessori programming. So our visual board is posted on all of our units. We have the resident name, the room number, what behaviors they have, the triggers for the behavior, the interventions that work with this resident, and the risks that are involved. Is it low risk, medium, high risk? So as I mentioned to you, we like to maintain confidentiality. So we're fortunate enough to display these boards behind the nursing station in the back room where there's a door. So that the shift that's actually coming on, in addition to hearing the report, they can go to the back and say, okay, I have Mr. So-and-so today. Let's see what his behaviors are. What will help me, kind of thing. So it's kind of like a cheat sheet, if you would like to call it that way. Instead of flipping through the chart or going on the computer to see, what interventions work, it's right there in front of you. So it saves you the time. Oh, I talked about that already. This is our behavior assessment tool. Quite lengthy. There's 3 parts to it. It's currently being completed by ourselves, the BSO team, in collaboration with the RPN on the unit and the PSW who looks after that specific resident, and we formulate a care plan based on that information. So let me show you what it looks like. I'm not going to go through the entire thing. At the back of the room there's actually the actual assessment, so you can grab a copy of it. It's so straightforward. But I'll just briefly talk about the next one. Okay, let me just do this. Okay, so this is part 2. This is initially what you're supposed to be filling out first. So for those of you who work in long-term care, you will see that it looks very similar to the CCAC application when you get what you get to the home kind of thing. So as you can see here, it divides it into different behaviors. So does this person wander? Is it new behavior? Is it a changed behavior, meaning is that something new? Is it a baseline, meaning is that the norm? Or is it not applicable at all? There's also a frequency scale and disruptiveness scale. So you rate it from 1 to 6. Is it every day? How bad is it? Things like that. You then enter the description of the behavior triggers and the current interventions that are now in place. So this tool is very unique in that, sometimes these behaviors don't apply to our residents, right? So now what? If you scroll down here, you will see other. So here you can put whatever you'd like, like drinks alcohol or something like that, and formulate a care plan based on that. Okay, so this is part, as I mentioned to you, I'm going very high level. All the things are there at the back. So this is our assessment guide. It utilizes the PIECES framework. I'm hoping that you're all familiar with that framework because this is getting to the root cause of the behavior. What's unique about this is that not only does it focus on clinical information, but it also, we social workers like to hear this, their strengths, their abilities, and who they are as a person, the social, cultural factors kind of thing. And this tool actually guides you, like, did you look at this? Did you rule out delirium? Did you rule out UTI? Did you rule out pain? Did you do this? So it kind of prompts you, and it's a very, very successful tool. It's implemented in all of the Central East Lynn long-term care homes now. It's helped tremendously. So I urge you, if you are interested in this, it's at the back of the room there. Okay, so I'll move on with my presentation. Okay. So we also have BSO rounds attended by our multidisciplinary team as well as our geriatric mental health outreach team and our pharmacist. We are fortunate to meet because we have all this manpower now, once a week. Okay. And this was also the biggest culture change it was so hard to change everyone's mind about this whole Montessori programming. Oh, that's for recreation. Let them do it. It's not part of our job. Well, yes, it is, because we're all involved in the residents' care. So that was our big challenge. How do we get the nurses to buy into it? How do we get the PSWs to buy into it? Luckily, they did it. So now we've done Montessori programming for each resident. They have their own kit. And, we try to figure out what to put in the kit. So we have a life history assessment that the PSW fills out. They interview the family. They interview the resident itself. So we are very proud of this initiative as well. So here are some of the Montessori kits that we have for some of our residents. And they are part of our team as well. And, a lot of people will think, oh yeah, it's very infantile kind of thing, but this is all they have left of their abilities. Like, they can only just pick up a pen and do, like scribble kind of thing. But that's important, and they need to feel that way. So we do a lot of, so these are just examples of some of the residents of what they've done here. Okay, let's move on to some stats. Okay, so this is a picture of I know it looks confusing, pharmacological approach versus the non-pharmacological approach. So PRN medications like your Seroquels and Trazodones versus Montessori programming. And you'll see that this has kind of stayed stagnant, whereas this has gone up from 0 to 175. So that shows a lot. So the way we do Montessori programming is that we do a behavior, like behavior charting. It's called DOS. It's called Dementia Observation System. And from that, we say, okay, Mrs. So-and-so acts up around this time, around shift change. Let's do a Montessori program for that resident at that time. and you'll be amazed what happens. Like we have a lady who pounds on the door because she sees all the staff leave, and we engaged her in activities, and now she no longer does it. And the staff work as a team, the frontliners, they say, okay, maybe she does want to go out. Let's take her out for a walk downstairs kind of thing. So she's gotten better ever since then. So that's just the number of behaviors that were identified by month utilizing the tool. This is quite impressive. We went from 83 to 52 now, based on all of these practices that we've been doing, pieces, You First, Montessori, all of that stuff. So we're very, very proud of that. Okay. There were some residents that we did have to send out to tertiary care to TRI, CAMH, Baycrest, and whatnot, Ontario Shores. We couldn't help that. The behavior got to a point where we have exhausted our resources and the behavior is still there. Number of Form 1s hasn't been too much as well, only 2. Not bad. Before it was like every month. Yeah. And these are the number of residents being actively managed by a behavior care plan. They are seen by our nurse practitioners. They are seen by the GMOT, the Geriatric Mental Health Outreach Team, the mental health nurses that come to your home. But they still stay in the home, so that's a good thing. Mind you, we collect about 14 quality indicators per month on this whole BSO initiative. So far, we've completed 43 behavior assessment tools, and we've discharged from our program 31 since last year. So, thank you very much. We're very proud of that, and, it was a team effort as well. So we're very proud about that. And we actually participated in a BSO focus group where a researcher came and interviewed the staff and the families on the whole BSO initiative. I don't know if I'm going to get in trouble by saying this, but I'll say it anyway. That's okay. Our wish was for all the homes to get it. That was our wish, because look how much we've accomplished so far, and it's working. So why not fund all of them? Hopefully they're not here today. Okay. So this is stagnant as well. So we went from 0 in January for the Montessori to 172 in December. That goes to show that how many non-pharmacological interventions really work here. Okay. So I talked about the pieces. We also use this approach. I'm not going to go into this as well. There's a lot of courses that you can take. This is a 2-day course. It's called GPA, Gentle Persuasive Approaches, and you'll see it in action here. And I talked to you already about Montessori methods in dementia. This really works for our residents. So let's get on to the success stories. So this lady, whenever you approached her, she would bite you, she'd scratch you, she would do everything under the sun kind of thing. And she also refuses to get out of bed. So basically the BSO team, my team, went in, got to know her, build rapport and trust and whatnot. And through effective communication, her needs are met. Talk to her, explain to her what you're doing in a soft voice, speak slowly, give her a choice. I know this takes time, but at least we're here to provide that time that the regular staff on the unit does not have. Because this lady, it would take you about 45 minutes to an hour until she finally gets up from bed, kind of thing. So we took our time with her and engaged her in a lot of things, and now she's fine. She's very religious. She likes to sing What a Friend We Have in Jesus. So a lot of the staff, they'll sing that to her and do the care while they're singing, and they dance with her and things like that. She's fine now. And we discharged her after a month. Yes?
So does she still take that long to get ready, or with all those information, the staff, what next?
It's cut in half. It still takes time, but they learned the skill on how to apply it. This lady. Okay. So this lady, she was exit seeking all the time. She pulls the fire alarm constantly because her son is actually a fire chief, and she thinks that when she pulls it, she'll see the sun. And we're like, oh dear, that's expensive. So management was, oh my gosh, they were just, oh my gosh, they were so upset. They're like, Leslie, that's $1,400. I'm like, I know, I'm sorry, kind of thing. But so she had long-standing behaviors, and she's smart. She'll pull the fire alarm, and then she'll go down the other hallway and down the stairs because she's mobile. Yeah. So again, this is teamwork again. Teamwork is key in all of this. So the VSO staff, we wrote a schedule out for her saying, okay, at 10 o'clock, Leslie will come and we'll take you for a walk. At 12 o'clock, Ernestine's going to come and we're going to go for a coffee in the cafe, kind of thing. So like things like that. Give her something to do, keep her busy, and this actually decreases the behaviors. Amazing. This fellow, we used the Pieces framework for this fellow. He's a good example, but I have a better one. We had a resident who constantly opened all the residents' windows in the middle of winter. She just went into each room and just opened everything. And your immediate thought is, okay, she's suicidal, she's this, she's that. But the VSO team said, hold on, does she have a PRN puffer? They went to the MAR, the Medication Administration record, and said, oh, she has a puffer. Let's give it to her and see what happens. It was fine. She never did it ever again. It was just like, that was my immediate thought. I thought she was, like suicidal kind of thing. But she's not. She couldn't breathe. So those are some of our success stories with that. And, I'll leave you with this. The BSO team would listen. This is from our resident. It's a testimonial. The BSO team would listen and help me as we spoke. There were those who helped me regain my cognitive power with special word games. There were the others who took me for walks and conversed with me about interesting news. They would have me write a journal and talk me through my emotional issues. All in all, I would like to praise them for helping me to regain a new start on life again. I am so grateful for their caring help. I can live out my life happy, content, and I feel useful again. Thank you very much for funding them. And I'll close with that. Thank you very much. Yeah. Oh, thank you. Oh, sorry. Oh, Betsy, hello. Yeah.
Thank you so much, Leslie. What a wonderful segue into my presentation. I'm here as Public Services Health and Safety Association, but also as the co-chair of the Behavioral Support Ontario Education Consortium. I co-chair that committee with Dr. Joel Sadavoy. So we're going to tell you about Betsy. Has anybody heard about Betsy? Oh, a few. Good. Has anybody heard about Dina? Dina died and Betsy took over. So I'll put that in context. So first of all, Public Services Health and Safety Association. We are the Health and Safety Association now under the Ministry of Labour, who provides service, health and safety education services to the education sector, the municipal sector, and the healthcare sector. So I was actually formerly from the Ontario Safety Association for Community and Healthcare, where I was vice president there. So we've, the safety system keeps restructuring in the province of Ontario. So we're, I think now version 3 or 4 of since I've been in the system for about 15 years. My interest is, even though I come from a nursing background, I'm passionate about worker health and safety. I think we have a lot of work to do to avert aggressive behaviors, responsive behaviors associated with dementia and Alzheimer's, and we have to prepare for the onslaught of Alzheimer's disease. And that is going to be catastrophic and is going to last a quarter of a century. And I say, as an aging worker, it's an investment in my future as well, and all of our future if we end up in long-term care, community care, and or have family members with Alzheimer's or a form of dementia. And there is a direct linkage and relationship between quality resident or client care and the health and safety of the workforce. And there is an abundance of evidence, and I didn't include it in my slide, I'm probably preaching to the converted, that if we adopt the evidence-based curricula, the dementia curricula, we're going to avert responsive behaviors and aggressive behaviors. And so that was my interest when Dr. Ken LeClaire approached me and said, Patty, will you co-chair the Behavioral Support Education Consortium? And I said, well, I'm not a dementia education expert. He says, no, but you've converted me when we worked on the DINA tool that we need to really look after the health and safety of our health care workforce. So that's my interest in all of this. I don't profess to be a dementia expert, although I'm very passionate about the good work that's been done in this area. So Behavioral Support Ontario, and Josie has certainly alluded to it, and she was the recipient of some funds, has done some great work. It really is summing it up, the right care at the right time, in the right place. It enhances the health care and services of seniors, families, and caregivers who cope with responsive behaviors associated with dementia, mental illness, addictions, and other neurological conditions in the home, long-term care, acute care, or elsewhere. So considerable funds have been invested in Behavioral Support Ontario to really start to advance the curricula and the adoption of the curricula by people who care for these individuals. The Pillar 3, the knowledgeable care team and capacity building objectives, was to strengthen the capacity of the current and future professionals through education and focused training to transfer new knowledge and best practices. And hence why the Education Consortium was formed back in about April, May of 2012. We were formed with the hiring of the additional 600 to 700 healthcare workers, and Leslie was a recipient of some of those, in this BSO project. So we wanted to ensure that organizations were making careful decisions about what curricula they needed, what training they needed, and to be able to make decisions with respect to that training, coupled with, looking at the core competencies. So we actually developed a matrix with that as well. So it was, we thought it was integral for organizations to make the right decisions. A lot of confusion. What's Montessori? What's GPA? What's PIECES? What's You First? What do I need? So the original DINA group, which became the Betsy group, we had representatives from OLTCA, ONUS, and several other organizations that helped us to customize this. So here we are with the BSO capacity building roadmap. You can see where the Betsy Education Consortium and the Betsy inventory fits in here, with all of the BSO capacity building roadmap. The Education and Training Committee, just to give you a high-level overview, we developed a committee, Joel and I, of about 22 members representing community and healthcare sector, which was really established to enhance the DINA, now we refer to as Betsy, to make sure that we get it out there so everybody can use it and make very careful and calculated decisions about the investment of education with their staff. So it resulted in the Behavioral Education and Training Supports Inventory Decision-Making Framework. There's actually an algorithm decision-making tool, which I'll briefly orientate you to, as well as the inventory. In the inventory, we have the curricula associated with mental health addictions and dementia. And the second part of the inventory is actually around the health and safety education that you need to do for new healthcare workers. And that's a really important aspect, as the Ministry of Labour will continue, and will continue through 2013 and 2014, to look at workplace violence in the healthcare sector. Because as you know, we have the highest rate of workplace violence compared to any other sector in the province of Ontario. So there will be a lot of enforcement activities around this. And I try to educate, and Dr. Leon Genesov, Chief Provincial Physician, who heads up the health care part of the Ministry of Labour, he understands, he gets it, he knows it's responsive behaviours. Back years ago, they would just come in and say it was acts of violence and you better do this and you better do that. So we've got a much better understanding, and they understand the complexity associated with caring with these individuals. So we have made some progress. So here's the members of the committee. you probably recognize some members there, but Representative Onus and OLTCA and BSO, both Matt Snyder and Sarah Clark, now Sarah Webster, represented, as well as people from the community, Sue Vanderbent and Sue Thorning, AKE, Barb McCoy, and RNAO, Doris Grinspun, and Josephine Santos. So wide representation. So let's introduce Betsy. It's a set of tools to determine the dementia education needs. So it's divided into sections. We had it out there, and we've got some feedback, and I'll share that feedback with you. People thought it was too long, so we now have a revised version to make it a little bit shorter, a little bit easier to go through, and we separated the sections. So Section A is Introduction and Overview, provides some context to what the work we did. Section B, very clearly, is the assessment tool to guide you through the process. So Section C, Sustaining and Evaluating the Assessment. What the minister said was we needed something that was going to be sustained. Education, we spend a lot of money in education. How do we know that we're sustaining the effect of that education? So what we did is we looked at some evidence-based leading practice in around sustaining the effect of education. So a little bit of work from, there was a subgroup in BSO, and then I introduced the work of Fixen, F-I-X-S-E-N. If you don't know him, read about his implementation science. He's from South State, Florida University, who really is, when I heard him talk, read his document, it was my aha moment for the sustainability of an intervention. So very interesting work. And then Section D is the Betsy inventory. So the decision-making tool, part 1, do you need education? Basically ask you to determine whether education is what your organization needs through a series of questions. The readiness for the education tool, you're going to spend a lot of money in getting that education, replacing workers, and so you want to make sure that you're ready for it in terms of making sure that you've got the infrastructure and the support. Part 3, A, selecting the most appropriate education for your organization. It's a checklist that will guide you, that will actually draw you to the inventory so you can make your choices. And then the program matrix and inventory, a clear description in that inventory of what GPA is, what the cost is, how long the training is. A clear indication from pieces, You First, Montessori. So it actually provides quite a bit of information to help you make that decision. And then the program implementation of sustainability, a little bit with more information to come on how you can sustain the effective education. What I'd like to do is incorporate the work that Shepherd Village has done in marketing this, because this is a perfect example of the good work of the BSO. So this is just an example of the algorithm. I'm not going to go in a lot of detail. You can actually access this entire tool at the AKE website. The inventory, as I said, was divided into 2 categories, clinical programs and health and safety training programs. And we actually supply all the health and safety training programs, and so if you ever need any assistance in that, we've got some skilled professionals that can help you with representation across the province. Here's the inventory for the clinical training programs. You can see quite a large, and it's actually out there now for acute care and mental health. So we want to know what else we should be including in this inventory. So if you know of other programs out there, let me know, because we need to get it in there. I think our project is up for renewal March 31st. We have to be done, so we're in the final phases. So do contact me if there is something missing. And some of the health and safety training program. We actually built the program infrastructure to support. I actually partnered with Laurie Shindo-Martin, Dr. Laurie Shindo-Martin, in the GPA program, and really got to understand the GPA with pieces in You First, and built the program infrastructure, the sustainability piece, in that Part 4 book, Preventing Client Aggression through Gentle Persuasive Approaches. And here, this is really busy, but so just let me tell you the columns. There on your right there, on your left, is the name of the curricula, and then the target population, the BSO target population, then the BSO core competencies, and then the BSO service function. So it really helps you to make that careful decision. So next steps. We completed phase 1. We moved or we transformed Dina into Betsy, enhanced the tool, added curricula. So we're now in the process of broadening the language so hospitals will use it and the community, and especially with the investment of the Ministry of Health and Long-Term Care in services in the community, we want to make sure that we've got all of that language built into it. We are continuing to add curricula to the program inventory, and we're looking for funds from the LINs to develop an e-tool. One of the things that we heard back from our stakeholders is that it would be much better in an electronic format. So stay tuned for more about that. And communication and promotion, I'm out there speaking about it. Sarah Webster and Matt Snyder are out there speaking about it. If there are opportunities for you to start marketing this and getting the message out, or tell us how we can get the message out, this is one of our main goals. We want people to be able to use the good work that's been done. And I thank you very much.
So thank you very much to Mary, Lisa, Jennifer, Leslie, and Patricia. I'm sure that each one of them were kind of cheated in time. They have so much to share with us, and we would have appreciated. I would have loved to heard more about all of your programs and initiatives. I think this has been a very timely presentation today as well, just simply given some of the environmental situations we've been experiencing in the last little bit as a sector. And I do suggest that as a sector, it's a great opportunity to sit down, to hear about what others are doing, and an opportunity to learn from one another as we move forward, not only to addressing, managing, and supporting the residents who are entrusted to our care, but also ensuring that our staff who work with our residents have the supports, the tools, and the confidence to be able to deliver on those care agendas in each of our homes as well. So thank you very much. I also want to recognize Surge Learning as well for sponsoring this presentation today in this workshop. We do have time for a few questions. I would ask if we could take 2 or 3 before we break for lunch. And before we do that, just to remind you, lunch will be in the, let me have a look here, the ballroom. It's a networking lunch followed by the research marketplace at 12:45. So if there are any questions, if you want to stand, I'll get the mic to you.
Yeah, I commend you for the work that you're doing. The wealth of information that's coming forward is amazing. I have a challenge for the researcher in that. Is it plausible with the tools and the information you're collecting, you can start to differentiate between residents with responsive behavior with the dementia and residents with responsive behaviors having a history of mental health with a dementia following. So that we can start to look at that, start to see, is there a difference in the responsive behavior, and then is there a difference in the assessment and then the management of that responsive behavior.
Would any of you like to respond to that?
Yeah, so I've mentioned to you before. So we've had some residents with a mix of the two. And does it apply to them, the actual behavior assessment tool? Absolutely. But you do need to engage your integrated care team. That's very, very, very important. So they've...
The documentation will.
Right.
In going further back from a research perspective, in building the tools, can you start to figure that into your reliability and your validity? That's the challenge.
Good question.
I know what you mean.
I just have a suggestion, and the Alzheimer's Society of Canada funds research projects. We don't actually do research ourselves, so I think that's a very interesting question because we view dementia as a mental health condition. That's our position. But to tease out the differentiation, it would be a very interesting study that I think would be very compelling for a peer-reviewed study to be looking at. So I would encourage, if you know people that may be interested in doing that teasing out, the Alzheimer's Society of Canada would welcome an application for that.
Any other questions? Yes, at the back of the room.
With the implementations that you've been doing and a lot of the great interventions that we're seeing the results with, have you had to
There were some changes. So our team, like it's the traditional 7 to 3 person kind of thing, but we decided to do 7:30 to 3:30 just to, I don't know, it was an interesting model, but it was suggested to divide it in that way. But they do work alongside with the regular staff on the units and apply and it's, like as I mentioned, it's a teaching role, it's a mentoring role kind of thing, and how we incorporated that, we're a unionized environment, so we did have some challenges with that. I'm not going to go into that, but I can speak to you after.
Okay, with that, we'll break. I'll ask the panelists if they wouldn't mind just sitting for a few minutes in case you have any individual questions you'd like to approach them with. With that, we'll close and enjoy the rest of the afternoon.